Hi, this is Andrew Usley. I'm the stroke coordinator here at Ogden Regional Medical Center. I'm going to go over the process of calling an inpatient stroke alert. What you want to do if you suspect your patient is having a stroke based off the BFAST signs and symptoms is dial the hospital operator, star 95000, their emergency line, and let them know where the patient is and that you need a rapid response in that area. That will bring the appropriate team to the rapid response. During that rapid response, you want to make sure that you're checking the patient's vital signs and blood sugar and communicating what the stroke signs and symptoms are based off that BFAST algorithm. In that time, the team will do a brief assessment of the patient, and if they deem that patient is having a stroke, then you want to call the hospital operator again, star 95000, their emergency line, and say, we have a stroke alert wherever the patient is. In that time, the hospitalist, if he or she hasn't already arrived, they should arrive. You should communicate the vital signs and blood sugar to the hospitalist, let them know what's going on. That will clear up, once the stroke alert's paged overhead, that will clear up the CT scanner. You want to get that patient immediately to imaging for CT, CTA, and back to the room. While that patient is going for CT and CTA, the house supervisor is grabbing the Blue Sky neurology machine that is located on the IMC unit. In that meantime, as they're grabbing it, they are also calling the transfer center for Blue Sky neurology eval. All stroke alerts should have a Blue Sky neurology eval. For some instance, if the physician doesn't want it, please note that in your assessments in Meditech or on your documentation, which I'll show you in a minute. So after that happens, you'll come back from imaging after the CT and CTA is done, and you'll have to call the transfer center. So usually the house supervisor will stick around and call the transfer center again, but please be an advocate for the patient and make sure the transfer center gets called again to let Blue Sky Neurology know their patient's back in the room and ready for the stroke evaluation. The Blue Sky neurologist, will beam in directly into the inpatient's room. So make sure you as the nurse are staying with the patient, going to imaging and back, and are there when the Blue Sky neurologist beams into the room. What will happen then when the Blue Sky neurologist beams into the room is they'll do an NIH stroke assessment, a full stroke assessment. The stroke assessment is done, the full one, after the patient comes back from imaging. A brief neurological assessment is done before the patient goes to imaging. So the Blue Sky neurologist is doing an NIH assessment, and they'll probably need your help moving a leg or whatever they need help with the assessment. So please stay with them. After that, they'll typically give their recommendation of whether they recommend a thrombolytic. We are currently giving tenecteplase for stroke patients if they are eligible. And they'll state whether or not typically if the patient has a thrombectomy. They're usually fast at giving that imaging results back while the radiologist is doing the reading too. So that's one plus of paging out the Blue Sky neurologist. They will talk to the physician. Hopefully, if the physician's not in the room, they will reach back out to the physician. Please be in close contact with the physician during this whole stroke alert process. So let's say the Blue Sky neurologist recommends a thrombolytic, the tenecteplase. Thankfully, the ICU nurse will be there with you through this, and they have the education on how to administer tenecteplase. An order has to be placed in the computer in Meditech for us to be able to administer tenecteplase. The pharmacist has 10 minutes to get that tenecteplase mix and up to the room. The pharmacist, once a stroke alert is paged overhead, it should be paged to their pager. I get a page too, CT gets a page, lab gets a page. That's how we know that there's a stroke alert patient, and that's how CT knows how to clear the table. So pharmacy is already waiting to see if they're gonna be bringing up that thrombolytic tenecteplase. Once they bring it up, hopefully the house supervisor will be looking for a room in the ICU unit. All patients that have get a thrombolytic or have a thrombectomy are supposed to go to the ICU. So they'll be getting that room. Patient will go to ICU. They'll get to the tenecteplase. The ICU nurse will administer it, but we'll need a second nurse to verify the dosage and sign off in Meditech as well. Let's see. In some circumstances, we will see that the patient has a large vessel occlusion on the CTA. In that instance, we are currently sending patients out to St. Mark's Hospital for a thrombectomy. A thrombectomy is where they remove that large vessel occlusion from their head. We will hopefully, our go live start date is in June, so we will start doing thrombectomies and be able to keep the patients down here. If you have any questions about the stroke alert process, let me show you where to find all your information that you will need. On every crash cart in the hospital is a lovely purple stroke folder. And this is the in-house stroke patient folder. In it, you'll find everything you need. So right here is a stroke alert flow sheet of what you do during an inpatient stroke alert. On the right here is a stroke alert tracker form. Yeah, there's a lot of boxes here to fill out, so just try your best in filling that out. What I really want you guys to do is try your best in filling that out. I could get some times from Meditech and from imaging if needed, but what I really want is the summary of issues, action, comments. I want what went well, what didn't go well, kudos, any issues. I just like a summary of what happened during that stroke alert so we can improve the process, not only for the staff, but for the patient care as well. In here, you will also find a purple NIH form that the physician or the nurse certified to do NIH can use to fill out. This form is our 24-hour thrombolytic thrombectomy nursing flow sheet that the ICU nurse will fill out if the patient gets a thrombolytic or has a thrombectomy. So that's ICU nurse documentation. This is a TIA scoring form, typically used more just in the ED to see if they should be hospitalized. So that doesn't really go for these inpatient stroke alerts. This is the Barnes-Jewish stroke dysphagia screen. Any patient that has a stroke needs a dysphagia screen before receiving anything PO. Let's say they don't get tenecteplase, then we want to administer that patient an antithrombotic, and usually that's aspirin. If they don't pass this dysphagia screen, you need to find another way to give that aspirin. In here, sorry, there's lots of forms in here. There's a lot of stuff that goes with these stroke patients. In here is the inclusion-exclusion form that the doctor might ask for. This is for if the thrombolytic, so the tenecteplase. These are the pictures that go with the NIH. So I've seen a lot of times with these stroke patients coming in with a stroke alert from the ED or inpatient, their blood pressure is high. Our recommended medication is nicardipine. Physicians, if they choose, they can also use labetalol too. So here it has the nicardipine parameters, where to start it at, etc., and the goals. I just want to take note that the parameters and how you adjust it is different from a patient getting tenecteplase versus non-tenecteplase. This is for a patient. You can titrate it every 5 minutes for a patient that's getting tenecteplase. This also goes through just how to administer tenecteplase, except what to monitor for, and this is the dosage form for tenecteplase. So when the pharmacist brings up tenecteplase, they'll bring it up in a box. Tenecteplase was typically used for cath lab patients, so they have a dosage on the box. Don't use that. There should be a little version card of this in the box, so you want to verify this dosing card or the one in the box with the ICU nurse. So just take note, because if you give the other medication, you'll probably be giving double the amount of medication. Also in that tenecteplase box, which I don't have here, and I'm sorry, is a blue wristband. On the blue wristband, the nurse will date and time the time tenecteplase is given, and it'll have a QR code on that. So that blue armband stays with the patient during their whole stay at Ogden Regional. Another importance of it, let's say we give tenecteplase and when you transfer them out, the other hospital knows that we gave tenecteplase in the date and time. Same for patients coming in from, let's say we get a lot of patients from Brigham City, they should keep that armband on. If it gets ruined, we can call out to pharmacy to get a new armband. So that is the basic of the inpatient stroke alert protocol. I know that's a lot. If you have any questions, my information's right here in the purple folder. So thank you for listening and taking your time, and you guys have a good day.